Thank you, Dr. Bala, for making me a part of this very interesting instruction course. And it is always a challenge to follow Dr. Ratnam. But I would try my best. And this is a case which I've learned quite a bit, and I would like to share my experience with you. So this is a 50-year-old male who presented to us with redness, severe pain. That is, that one-sided pain was unbearable, and blurring of vision in the right eye for 15 days. He had no predisposing trauma, surgery, or any systemic disease. His treating ophthalmologist locally had done some investigations. ESR was around 30. I have just picked up the important ones. So he had a positive ANA, and as per his records, he had a C-reactive protein which was raised. Now, as Dr. Ratnam had mentioned earlier, the range is up to 6. So this was 7. So it was not too high, but it is definitely on the borderline. He also has a history of just joint pains, and I think this was more of a leading question asked by his ophthalmologist, but that was definitely on the file. So when he presented to me, he was already on oral steroids, 60 milligrams per day, and also on topical steroids since 1 week. And when I saw him, his vision in the right eye was 20/30 and in the left eye was 20/20, and he had almost the same symptoms when he came to me. So this is the picture which he had. So this was a diffuse scleritis. And normally when we see a diffuse scleritis, we look for any areas of whitening, yellowing, any pus formation. So he didn't have any. And he had severe pain in that eye. So at that point of time, because he had not responded to medications, 60 mg, at least he should have had relief with pain. My slides are not moving. And the cornea otherwise was okay. So I thought, let's just get a few other investigations like C-ANCA and rest of the investigations. But he refused everything. And I also wanted a B scan at that point of time to see what was happening and whether he had some posterior scleritis as well, which could account for the pain. He refused everything. And he came back to me after 3 days with worsening of pain. And there was a drop in vision to 20/60. And when I saw his fundus, he had a peripheral choroidal detachment inferonasally. So at that point of time, there was a slight elevation in the nasal aspect, but this was something which was not very typical of what we see in infectious scleritis. But this was something which was not there 3 days ago. And this was something which was very interesting because he had these endothelitis-like presentation temporarily and a lot of debris in the cornea like this. Now, this kind of pattern we normally see post-corneal ulcers or during corneal ulcers where you have a lot of inflammatory debris sitting on the endothelium. So this was something like that. And we did a B scan, and then there was a T sign over there with choroidal detachment. So at this point of time, we said, though there was no marked yellowish lesion, so we said, okay, let's at least go with the needle and go under that area of a slight bulge which was there, explaining the risks to the patient. And what we did was, there was definitely pus fluid which was there. And there's so much of necrosis on cytology, and this grew actually Pseudomonas aeruginosa. So this patient was started on oral ciprofloxacin, and after 2 weeks we had to even start steroids because many of these conditions is a lot of immunological mediation, so which will require steroids. And if you see the improvement in the scleritis from this was the initial, the subsequent, the time when everything worsened, you see this debris, and then you see things starting to clear off with thinning of the sclera. And then you can start seeing this organization of these exudates on the endothelium. And then this is at the end of 2 months, and this is after 4 months. So this person needed ciprofloxacin for nearly 4 months, and you can see more or less it is quiet. And by then he had a mild proptosis also due to the inflammation, and things are now settling well. So I would just like to go back in this case. So here was a case which had no predisposing factor. There were no areas of pus pointing, necrosis, abscess, satellite lesions, anything which normally you see in infectious scleritis. And this was misdiagnosed as autoimmune, mainly because of the ANA positivity and the CRP and the ESR. And somehow, because everything added on, the the ophthalmologist also asked for joint pains, and that also was taken as something very significant. But there were a lot of pointers in his clinical history which was missed earlier. So the severe pain and one-sided headache, very severe, is usually, you normally see it in infectious scleritis. And one needs to have a high degree of suspicion when there is no improvement with such a high dose of oral steroids for at least even a week. And this new presentation of endothelial debris, which is occurring with a lot of folds, definitely should point out to infection. And whenever you're in doubt, it's always safe to just take a needle and carefully under the conjunctiva to just look for any pus which is there, and subject that to both microbiology and cytology. Now, the bacterial scleritis is the most common form of scleritis, and out of the bacterial, usually the Pseudomonas is the most commonly isolated organism. Now, this patient, though we had recommended ciprofloxacin before the cultures came, he wanted to get it treated locally, and he was started on cephalosporins. And he didn't do well for about 3 days, which was worsening. And a simple drug like ciprofloxacin is very useful in Pseudomonas. And with a good dosage of 750 mg twice a day, he definitely did very well. So the lesson which I learned, and I would like to share with all of you, is infective scleritis can come even if there is no predisposing factors, especially in our part of the world. And this can highly mimic autoimmune scleritis, and therefore we should always have a very high degree of suspicion when we see our patients with scleritis, and follow them up very closely if the pattern is changing over a period of time. Now, bacterial and fungal are quite common in our part of the world, and an important drug like ciprofloxacin, but should be given in adequate doses, along with oral steroids. Once you start seeing the symptoms or signs getting better, if you add the steroids, this definitely helps in Pseudomonas scleritis. With this, I would like to end this case, and any questions awaited.
Kalpana, what is the source of infection of Pseudomonas here?
See, in this patient, we don't have any trauma, but he is a farmer by profession. So in India, especially people from the rural background, many times even if they are exposed to the sand and the dust,
you are thinking
we don't know, and they don't come up with that history. So that could be one of the causes. Because he also had an MRI and all done. I didn't add this because I thought that would take a lot of time, but his sinuses were clear, and there were no focus of infection anywhere else in the body.
Apart from the Pseudomonas, another cause of scleritis could be nocardia.
Yeah,
can also
especially
be that one.
in rural.
And toxoplasma can also produce scleritis. That's been reported. But these are the very rare forms of scleritis.
Yeah.
So one should not go with the idea that autoimmune scleritis would be the top on the list of your
I think that is the reason why the ophthalmologist also started him on oral steroids, which actually even I would have done initially. But after 1 week, even if you don't see and it is worsening, it is always better to keep our eyes and ears open. But I thought what was interesting in this patient was that endothelial debris which was there, which we normally see in infections. And that was an important pointer for me to go in subconj and see if there is any pus.
Did you scrape, Kalpana? What did you?
No, there was no areas of necrotizing scleritis, which was visible obviously. So what I did was with a insulin syringe, I just went under the conjunctiva. And at that time there was a ooze. And and that I took it out and sent it for examination. So that was mainly on just a suspicion because of the debris which was there in the endothelium.
You look for AB also, no?
Yes, sir. Normally we do for bacterial, fungal, and
Very nice presentation, Dr. Kalpana. Do you consider the contamination by the betadine, which you have applied before?
This was done. No, this was done in the OT itself. No.
OT was done, but the before taking sampling, you must have applied the betadine also.
No, we didn't apply.
No.
No. But how would that change? Even if you had.
With the betadine, sometimes we may have that Pseudomonas. With the betadine, you are putting before the you can say, before
He's
taking
trying to
out the
say that
sample,
Pseudomonas grows
Contamination of this
Yeah,
thing.
by
No,
the-
but this is in the OT.
no,
And it
in the
responded
OT
with the antibiotic.
in the OT. Yeah,
Huh.
that is the only thing. And the cephalosporin started previously must have done that job for the Pseudomonas also.
No, cephalosporins, at least the ones which they gave, did not work on him. So we were awaiting the culture for 48
Culture
hours
and
and sensitivity.
Yeah, we have proved that that cephalosporin was not, you can say,
Useful. So this person, actually we had advised ciprofloxacin. We had actually advised IV Cipro at that point of time. Sorry, ciprofloxacin, but he wanted to go to his, back to his rural place. So there they felt because it is an infection, let's give a higher antibiotic.
this is my point that if we have taken the Pseudomonas and we have done the culture sensitivity also, then it may, you can say, more proven your case that Pseudomonas was unresponsive to
Yeah.
that cephalosporin.
Yeah, so that's what I showed a culture swab, which was sensitive to ciprofloxacin
But
and
resistant to that?
which one?
Resistant to the cephalosporin. Why?
No, that we don't know. Yeah,
So
because
if-
no,
if-
but the
if we would
sensitivity
have done
chart.
that, yeah.
Sensitivity chart, the highest sensitivity was for ciprofloxacin, gatifloxacin, the fluoroquinolones.
Yeah.
And in that,
Cephalosporin,
it was, they had not done for that particular
Yeah.
cephalosporin.
That's my
Yeah.
point. That if
You're
you
right,
would
yeah.
have done that, then it
Yeah.
would be a stronger thing
Correct.
to rule out the contamination.
Correct, yeah. But he responded extremely well, and this is very
See,
characteristic.
When we give multiple treatments, we sometimes don't know that what have clicked.
No, see, but if
may
it
be
is
the ciprofloxacin, it may be the another thing, or it may be the time.
any antibiotic, if it is an infection, within 48 hours of starting an antibiotic, you should start seeing response to at least symptom-wise or maybe the signs. Signs may be a lot later, but you would stop seeing progression and symptoms get better. Now, in our case, there was a 1 week of oral steroids and he worsened with development of choroidal detachment and endothelial debris. And then he was started on cephalosporins by his local ophthalmologist and it was worsening. So his pain was worsening. He just could not, he wanted to take his eye off. So definitely we knew things are not working. And at that point of time, we just started ciprofloxacin. And within 48 hours, his pain came down. And we knew it is not, he may not respond dramatically in 48 hours, but he did not worsen either. And that's the time, because that 1 week is crucial, because once you feel that it is getting better, then you add the steroid. Because there's a lot of enzymes which are released by the Pseudomonas, which worsens, it becomes immunological component also. And that is taken care only by oral steroids. There has been a controversy with Pseudomonas scleritis, but there was a paper which was published recently, and that shows the efficacy of adding steroids with, they had 2 groups, and Pseudomonas scleritis, definitely you do require oral steroids with the proper antibiotic.